Hi, everybody. Welcome. It is Friday, noontime Eastern. Hope you're getting ready for a good weekend with the AAP. AAP has had some good programs. And so if you haven't registered for that meeting, not that I'm working for the AAP, but it's worthwhile. Besides that, if you're member of the AAP and you register, even if you can't make it to the events either last weekend or this weekend, for those who've registered, those events are going to be available to us for a full year. And so that we can view the events at our leisure, get our continuing education credits. I think there's something like 39 CEUs, which we can get from our own homes. Also, if we register, then that takes care of your every 3 year requirement. So it's a good thing, although it's going to be in Miami next year, so I want to see you there. It's a good thing. For those of your members, Danielle's done some material which I'm going to send out to you next week. It's going to be how to handle this year-end rush. So you'll be able to use some of the techniques that we've been able to employ successfully right here. So the webinar is going well today. I thought I'd take it a little bit, make it a little bit controversial. What do you do? What do you do when you see something that you say, well, somebody else should have seen it? So we'll go over that and just see what we can do. By the way, I thank the Oral Reconstruction Foundation for providing us with a continuing education credit. So let's take a look. Okay, so we take a look at today's session. The intake call is this. The patient called for herself and her husband, who's also scheduled the same day. She said she saw our article in Florida today. I wrote for Florida Today years ago. I don't know where that came from, but I found out later on she's been coming here for 40 years. So I was a columnist for about 5 years. So that was probably where it happened. Just goes to show you, public relations does not go unnoticed. And even though I haven't written for Florida Today since probably 2015, maybe 2016, it makes a difference. Anyway, she wants to be established with a periodontist in Florida. They just moved here. She feels like something's wrong with the tooth. She's scheduled on Monday. And so I saw her last Monday. I called her, as we do with the doctor calls. She's been a snowbird here for 40 years. She has lots of dental work and implants. Implants were done by a doctor, and I won't give the name, of course, who passed away in 2019. She comes in, the briefing notes from the assistants are after the assistant has taken the examination, done the CT scan, done full x-rays, and done photos, and finds no allergies in the medical history. The patient presents today to get established with our practice. And was a previous snowbird. So no new information. She's being treated for high blood pressure and is taking a statin drug. Blood pressure, as you can see, is 142/81, pulse 68. So there she is. Okay, there's 81-year-old. She looks good for 81 years old, doesn't she? Okay, so teeth look nice. That's good. So let's take a look at the photographs. And the photographs are looking good. You can see there's full mouth crown or bridge work someplace on the upper arch, most of the lower arch, except for the lower anterior teeth. If we take a look at the upper right side, you'll notice a little fistulous tract coming from the number 5 area. Okay, so let's continue. This is the upper left side, looking good. And there's the occlusal film. You'll notice that she's wearing, these are reversed, so this is actually tooth number 10 that has some lingual wear. And I'll mention that the assistant, during the time of the examination, when I'm talking with the assistant, I'll say, you know, she's wearing her teeth. She's worn right through the porcelain, right through the porcelain on the crown on tooth number 10. Okay, when we're talking about bruxism, that's what it'll be. And also you can see the bruxism here. And in projecting photographs, we can talk to the patient about, you see how there's 3 layers here? This is your enamel. This is your enamel. This is your dentin. When this tooth first grew in, it was only covered by enamel. The only way it can be like this is if you're wearing it. You know, if you're grinding on that tooth in some way, there's a great deal of wear. And you see, notice the same thing right here. You see this 3-layer effect. That's not normal. That means there's been some wear that's occurred over your life. Let's take the full mouth series of x-rays. When we look at the x-rays and we see Through here, you'll notice, I'll show you the areas of concern, but you notice this right here. So let's take a look first at the upper right side. What do we see there? Okay. And this is the first thing I'll say to the patient. No, I'm seeing a dark area at the end of the root. It should not be there. It shouldn't look like that at all. Well, does that have something to do with that fistula that you found on number 5, which I'm also going to mention out loud? No, this is far behind that. So this is something different from number 5. Now, on the upper left side, you've got a big infection. Take a look where that infection is. And that infection is very close to where the sinus is. See this white line right here? White line is separating the sinus from the oral cavity. And so bacteria can get up through this area and can actually perforate a hole through the sinus. And I've seen that lots of times in my career when teeth are held on too long for whatever reason. We have to take, and then to take care of a tooth like that requires some significant surgery to close the sinus. So we want to take care of this before that. She said, yeah, I know. I had this area operated on twice. They were trying to remove something and they didn't. Well, you can see here's the remainder of root number 13. Okay. Well, how come my other doctor didn't mention this? I can't tell you about that. All I can say is that I see this today. You see it? We see this dark area right here. Okay. So the question is always, how come my previous doctor didn't see it? And if that's the question, the answer is not something that you address. You answer that question essentially with a non-answer, saying, I don't know what happened then. I can tell you what I'm seeing right now, and this is a severe infection. I'm really concerned for you. This is not a dental problem. This is a health problem. We don't want to involve the sinus in a dental problem. So we have to take care of this. And we just move on. We don't go and answer that question at all. Let's go through the CT scan a little bit and see what we see. Okay, so we're going through the upper right side. Sorry for the buzzing of my phone. I'll put it someplace else. Okay, and you'll notice that the lucency in here, there's a dark area that goes right around the end of the root. Remember we talked about the sinus? Take a look at the sinus membrane. The sinus membrane is becoming inflamed. So we can move through this area. This is on time lapse that I've already pre-recorded, so I can't stop it and go back very easily. But you got the idea. Bone here is good for dental implants. Not that we're considering dental implants at this point, but you'll notice the bone width is quite nice. We're going over through the left side. Now we're going to go hit the implant. There's an implant, single implant in the number 12 area, right? And now here's 13. And notice here's where the dark area is right here. And this is the sinus wall right here. Now it's draining, and that's why you don't feel it. Okay, and there's that little root. There's that little root right there that remains. Now the bridge is being held on to those two teeth as well as the last tooth on the upper left side. And the last tooth on the upper left side is doing fine. Let's go to the lower arch. There's not much going on in the lower arch. I don't think you're going to find anything that is of significant concern here. So we just keep on scrolling through here. Again, scrolling so the patient is seeing it. And we can say here, this implant is done really, really well. Look at it. It's right down the center of the bone. That's doing really, really well. We want to make sure the patient knows there are good things here, as well as the bad things we're about to talk about. So now we're doing our examination. The examination is done on a checklist. So head and neck with the normal limits, infraoral, moderate lingual tori, and I'll say those are these little bumps on the inside, just as you do. Okay, number 5 area is a red spot in the facial with a draining fistula. That's a draining infection that's coming out of the gum tissue. Important to use words that the patient understands. So I might say fistula first. Say that's an infection that's draining out through your gum. Angles class 1, fremitus, there's no fremitus, overbite is 50%, overjet is 0, and there's no crossbite. We ask her if she grinds her teeth. She says no. I don't argue with her. All I do is show her the wear that's going on in the teeth. Here's the wear. Here's what we see. Tristan is moderate in the anterior, abfraction and erosion. We don't feel that. Open and close your mouth, okay? There's a late opening click on the left side. So I feel a click when the patient opens her mouth. Malampati score, we've talked about that before. That's an anesthesia measurement, but it's one more quick examination that you can do in order to be able to see what the patient's risks are for intubation. It's a simple test that can be done, and just adds to the bit of, or adds to the knowledge that you're creating when you're doing this examination. Palatal wall is normal. The gum tissue is firm. Let's take a look at the pocket depths, and I want you to look particularly. I mean, you'll see some 4s here and there. When you're seeing this little thing, it means it's greater than 10. Okay, so that's tooth number 13. Remember, we talked about tooth number 13 as being one that was involved with severe involvement. But look at what's happening at number 13. Okay, at number 13, there's no pocket on the palatal. There's no pocket on the mesial. There's a severe pocket greater than 10 on the distal. What does that mean? Well, maybe number 13 isn't quite as bad as we think it is, and maybe number 13 can be saved. You know, when we publish results, we take a look at teeth like this, and we say, all right, we can treat them. Or we tell the patient we'll treat them, and then we come up with these miraculous results. Because don't forget, there's a root tip in number 14 that needs to be removed. So I'm not saying that's what we're going to do, but it's certainly one of the options that we can take. And I'm encouraged by the fact that there's no pocket in the mesial, there's no pocket in the straight facial, no pocket in the palatal, and there is the opportunity for regeneration. Can I take it to the bank? No. And you'll see how we develop the treatment plan in a moment. So let's take a look again at that tooth. So now, is it possible that the infection that's coming from the root on number 14 has traveled over to number 13 and has dissolved the attachment on the distal, and all of this is coming from tooth number 14? I kind of doubt it. But the periodontal probing indicates that periodontal is intact here. Maybe there's a failing root canal at the apex of number 12, and that's what's the apex of number 13, and that's what's causing the involvement. Sure could be. Sure could be a failing root canal. There could be some erosion here, or some kind of resorption here. There could be a lot of different things. At least from a periodontal standpoint, the tooth is intact. Do you want to take the chance? Is it possible you could remove this root, reflect the flap, perhaps even do an apicoectomy here? Yes, as periodontists, we can do apicoectomies too, and fill this area in without taking out the bridge? I think you'd like to do that. I can tell you the many times the patients have given us permission to do that, and it's been a lot of fun, and we've learned a lot. And we learned that the patient does have the capability of healing. If we get rid of the sources of the infection, the patient will heal. It's very easy to say we'll extract the tooth, but until you treat it, do you really know whether you had to extract that tooth or not? Okay. So, bleeding is modeled around the implant, number 30, number 20, number 10, number 30. I don't know what that's. Okay. We put 30 twice. Calyx is light, plaque is light. Just good care for mouth. Okay, so problems we see, and I will enumerate the problems. We'll give the problem list out loud so the patient hears it. Okay, problems, we've got an abscess around that last tooth on the upper right side. That's serious. We've got to do something about it. Second, we've got a draining fistula coming from a tooth that's already had a root canal. Third, we've got a fracture root numbers 12 and 13. Actually, that fracture root should have been 13 and 14. Then there's an implant in place in 12 and 13. So ignore that. Instead of 12 and 13, that's 13 and 14. Okay, number 12 is an abscess going into the sinus. That is a fistula. No, that was number 13, and number 14 has the broken root tip. So I got this a little bit out, and sorry I didn't catch it before I projected this for you. And there are no issues in the lower arch. Okay, so I start talking with my assistant. Here are the different plans that we could do, and I do this out loud. I do this out loud in front of the patient, so the patient can know what I'm thinking. First option may not heal. We've got a 50-50 shot, or maybe not even a 50-50 shot, and that is to hopefully save the bridge, do a PRF, and do a membrane around, and do a bone graft number 13, using the materials we're going to use, flap, extract number 14, the root tip. Okay, so in other words, we're going to flap it, bone graft, if it goes around the apex, we would do an apicoectomy there, and do an apicoectomy to the point where there is good bone coronally, and try to save the tooth that way. Do you think that's a good option? Some people will say yes, some people will say no. It's the patient that I want to educate. And of course, I'm going to educate the patient a little bit of the chair, and I'm going to give my assistant enough information, because my assistant, all three of my financial arrangements assistants, know how to discuss this problem with the patient in detail after I leave the operatory. So I can introduce the concept, make sure that they've got it, and then they can discuss it with the patient, always knowing that I'll tell the patient, you're going to discuss this with Jennifer. Jennifer come, and if Jennifer can't answer your question, she's going to come and get me anyway. Okay, so have a good time talking with Jennifer, because she's going to be able to speak about it in more detail, and probably in terms where you can understand it better than I can. Okay, next, the other treatment plan will be remove the bridge, extract number 13 and 14, and don't replace numbers 13 and 14, okay? And just leave her with number 16 and leave her with number 12 to chew on, with nothing in that space, okay? Another way to sever the fixed bridge on the mesial number 16, extract number 13 and 14. Do a bone graft in the number on the upper left side using a large membrane PRF and Mineros. Do an internal sinus lift later on, number 13 and 14, and 15 possibly. And do implants abutments numbers 13, 14, 15. Does that sound like a good treatment plan to do on an 81-year-old? I don't know. I don't think so. Do you? It's pretty ambitious. It's pretty expensive too. Okay. Or we could take out the bridge, keep number 16, take out the bad roots, numbers 13 and 14. Let the area heal. I mean, we may have to do some patching with the bone graft. And then later on, do a fixed bridge utilizing number 12 and number 16. Okay, 12 is the implant. 16 is the natural tooth. And what we would do would be to make a telescoping crown. In other words, we put a custom abutment on number 12. We'd parallel that with a telescoping crown on number 16, so that 12 and 16 are parallel to each other before putting the bridge on, and then we put the bridge on with temporary cement. So you have the advantage of frictional retention, because you know the coping on number 16 is going to be parallel. We'll have a typical 77-degree taper on number 16, along with a 7-degree taper on number 12. So you're coping, parallel coping meaning 7-degree taper, you have those two match, 12 abutment and 16 coping. Then you can put on a fixed bridge and cement it with temporary cement, so if there is some trouble, you can just knock it off. If number 16 is slightly mobile, would we do that? The answer is probably not. 16 was pretty tight. Even with failure of numbers 13 and 14, 16 was pretty tight. Even with all the cantilevered fixed bridge materials, 16 was tight. So I think on an 81-year-old, this might be an option. Utilize the implant number 12 and number 16. Is it too far to go? We advise the patient, listen, an ideal plan would be do an implant plan. I think we can get away with this. And we'll try to do everything we can to make it as successful as possible. It'll minimize the amount of surgery that you have. And frankly, will get you functioning faster if we do it that way than with any of the implant approaches that we were talking about. Okay, so she said she wants to schedule one side at a time. She knows both sides are abscessed, so she decides she's going to schedule the upper right side first. Now, she's on a statin drug. So what do we know about statins? Statins remove CoQ10 to a level up to 45% from the internal aspect of the cell. And so mitochondria don't function as well. It means that people may not heal as well. So everybody who is on a statin drug will take ubiquinol or coenzyme Q10. This is the most bioavailable form of coenzyme Q10, ubiquinol. They'll take it with every surgery, at least 200 milligrams, at least 100 milligrams per day. Okay, and for everybody, we prescribe vitamin D. Rick Myron just gave a beautiful presentation on implant failure and how vitamin D is responsible for failure more than any implant failure, more than any other factor. Twice as many people have implants that fail when they're vitamin D deficient than when they're smoking. It's important. How much vitamin D do we have them take? 5,000 international units a day. Some people say 2,000 international units a day. Okay. It isn't that important on the short-term surgery. We want them to take the vitamin D 4 weeks in advance before we do the surgical procedure. They're not doing it already. We do that for that period of time. The instance of failure will go way, way down, particularly implants. I can't tell you about tooth failure. We're talking about implant failure. That was what was measured in that study. But, teeth do pretty well. I did have patients fail way back before we knew about the relationship between CoQ10 and statin drugs. I had patients who failed. I just happened to have some CoQ10. The healing just wouldn't, the soft tissue healing wouldn't go fast. They were slow healers. And I gave one coenzyme Q10 and a slow healer, and she healed it within 3 days. 2 or 3 weeks later, I had another one that was a slow healer. Gave him coenzyme Q10, healed up right away. So if you're having slow healing problems, take a look and see if those slow healing problems have to do with your patients who are on statin drugs. And if they are, give them some coenzyme Q10. Watch the magic occur. It was amazing. I mean, this happened in my practice. It has to be about 25 or 30 years ago. Okay, we're also going to refer the patient to the endodontist to look at number 5, because don't forget there was an apical on tooth number 5, and it was draining. We had the draining fistula. Okay, total of the treatment plan is whatever the dollars are. She paid for the upper right side surgery today, and she scheduled the visit for treatment number 1. That's going to be next week. Okay, and then we gave her consent form so that she could go see Dr. Jones. Well, shouldn't she take care of the upper left side? Yeah, she should. She should, but she knows it's been going on for a long time. She wants to treat one side at a time. That's fine. The right side is simpler, simpler surgery. We let her know that. And so we'll take care of the right side first. Once that's healed up, then we'll do the left side. And so we always put next visit. Next visit in your chart is important. Rather than go through notes, just list next visit and put NV so you have an idea as to what the next visit will be. Who knows better than the assistant of the chair at the previous visit what the next visit will be? So rather than thumb through a lot of notes, NV is a standard notation that we have in every single chart note, or at least it should be. Okay, so at the chair, I'll then dictate. And the purpose of the dictation is 2. Number 1, I want to make sure that I have it right. Number 2, I want to make sure my assistant has it right because he's already written down the treatment plan. Number 3, who knows what the patient is going to overhear, and the fact that we're so thorough by dictating at the chair, which requires a little bit of preparation and certainly a little bit of presentation skills. But, it's with anything. You practice, you practice, you practice. So I said, dictate into my phone. Smart Recorder is the app on my phone. And that goes, I upload it straight to my daughter, and my daughter will type it out, okay? So we see so-and-so for evaluation has been followed closely by Dr. So-and-so who is now deceased. Unfortunately, she presents with significant infections. Tooth number 1 has an infection that is encompassing the entire root. There's no way that tooth can be saved. It's part of a fixed bridge number 1 through 2/7. Tooth number 1 should be severed from the existing fixed bridge with tooth extraction, and no bone graft will be necessary. On 13 and 14, we have number 14, which has a root tip remaining. There's a failure of the bone support on the distal number 13. I'm not certain whether number 13 is an independent lesion or whether it's coming from number 14. This would be determined by exploratory surgery. And then I'm giving the different options that are there. I'm not going to read them all to you. I just gave them to you. Okay, so we talked about what we would do if we were to save the bridge. Now we're talking about what we would do if we did the major implant approach. And what about the third approach? If I didn't want to take any chances, and the patient wasn't up for multiple surgeries, I'd sever the fixed bridge. Remove 13, 14, the product 15, wait for the area to heal, and hope that number 12, the implant, and number 16 are going to be sufficient to support the new fixed bridge. On the upper left side, that should have been the upper right side, is officially coming from the apex of number 5. I want that referred to Dr. Jones to see whether we can take care of the apical lesion by apicoectomy on number 5. Other than that, there are no problems, and a PM or preventive maintenance and maintenance procedures are indicated, signed by me, carbon copy to the endodontist. I want the carbon copy going to the endodontist. By the way, if there's a medical problem, I want a carbon copy going to the physician. I want as many copies of this dictation going out as are appropriate. Why? I want every doctor who's involved in the case to know that we're helping the patient. Number 2, even if the doctor isn't directly involved in the case, like the physician, if the physician sees that we are careful in the way we develop our treatment plans, or that we do dental implants, or we do perio, whatever it is, then the doctor knows, oh, if I'm getting a bunch of letters from this dentist speaks like me. He does diagnosis, he does treatment plans, and he speaks like me. If I need a dentist, or if a patient needs a dentist, maybe I want to refer to this person because of the nice letter that he has sent to me, or that he's carbon copied me in on. So it's good, it's important, it works. What are the considerations when a patient comes in? The patient said, well, my doctor never showed me that. Do we really know what the doctor, first of all, we know the doctor died in 2019. There are a number of different possibilities that can occur in every single event. You know, we think we see something, we know the cause. We don't know the cause. We think we know the cause. If we were there at the time of the cause, then maybe we'd be able to see 6 months or a year later and say, oh, of course, I caused it. But if I wasn't there, I don't know. Number 2, we do not want to cover the backside of the previous dentist. Okay, we're not there to treat the previous dentist. I can only provide my findings, let the patient know what the findings are. That's my patient. And the patient trusts me to tell him or her the full information. Never looking at the other dentist. Okay? I'm never covering. I'm never turning away. If something is wrong, I'll let the patient know there's something wrong. Why didn't Dr. So-and-so? I don't know. I wasn't there. I can just tell you, this is what I'm seeing right now. I think it's a problem. I think if we don't treat the problem, thus and so is going to happen. Let's take care of this. Okay? Just let it be handled like that. Let the patient handle everything else. Patient entrusts you, patient seeing you for the examination. Make sure that you give that trust back by letting the patient know exactly what's going on. Not by blaming the other guy, no, but let the patient know exactly what's going on and what kind of trouble he or she is in. You do that and you'll take care of all of the other problems. Will the patient get mad at the previous dentist? Yes. If I covered the rear end of the previous dentist, would the patient still be mad at the previous dentist? Yes, and be mad at me too, because I'm not telling the patient the truth. The patient will eventually find that out. So let's be very, very straight up with the patient. It is a trust issue. We are diagnosticians first and treaters second. And we let the patient know what the diagnosis is. Let the patient know what we should do. And all of the other pieces will fall into place, likely not creating any havoc for anyone. But understand, our contract is between the patient and us, and no one else. We are not treating the referral source. We advise the referral source. We let the referral source know what's going on. We let the referral source know what we told the patient. But beyond that, we are the patient's doctors, treating doctors, and that's who we are loyal to, okay? Any questions? Let me get off the share and see, are there any questions that you have? I'm checking the Q&A box. Okay. You'll all get your, those of you who've been on for most of the session will get your continuing education credit in the next week or so. I hope to see you at the AAP. By the way, we will have a meeting of the AAIP. It'll be an affiliate event. Anybody who wants to come can come. And that'll be at 4 p.m. Eastern, 1 p.m. Pacific, tomorrow, Saturday. Just check American Association of Independent Periodontists. Check that in your schedule on Saturday. Just check that. I'd love to see you there. And we're going to talk about what we do in order to be able to build our practices up in spite of the referral model, and maybe even support our referrals better. It'll be a good talk, and be about, I think, from 4 to 4:45 p.m. So I hope to see you there. Otherwise, I will see you again for our treatment planning session next week, Friday at noon Eastern. Thanks. Have a great weekend. Bye-bye.